Hello, everybody. We have lots of people joining us today. Thank you so much for signing up to this session. In fact, we've even got about 300 people registered, so I can see lots of you joining now. And in an effort to keep it on time, I am going to get started, and people are welcome to keep joining as we get going. My name is Jen Hutchings. I'm the Philanthropy Manager at the Perry-Cross Spinal Research Foundation. And my job is to run the session today. We don't do many of these, so please be kind to all of us as we work through this technology. To get started, I'll just talk through how the session's going to work. In a moment, I'll introduce the panelists. Then there'll be a short presentation. And after that presentation, there'll be an opportunity for all of you to ask some questions to the panelists. And you can do this in two ways. You can use the raise hand button, which is at the bottom of your screen. If you have a look, if you click on that button, it will alert to us that you're interested in asking a question. We will then unmute you and you can ask that question. Please just be aware that your video might turn on when that happens. Another way to ask a question is to use the Q&A box, which is also at the bottom of your screen. And this is a monitored way for all of us to keep an eye on the questions that you're interested in. So there is the raise your hand option or the Q&A section option. And if I could just ask you not to use the chat for questions, please, just because it's a little bit hard for us to answer various options. I know that lots of you have sent us questions ahead of time. Thank you so much. We've also got those questions here and we will be asking some of those tonight as well. If we run out of time, because we will stick to time and close this session at 5:30, if we're running out of time, please don't worry. We will make sure that we circulate an email address to each of you should you want to liaise with the team at Griffith about your specific question. But our hope is tonight that you will have a lot of your questions answered, particularly after you've watched the presentation. So let me introduce your panelists. We have Professor James St. John, who's the head of the Clem Jones Centre for Neurobiology and Stem Cell Research. Perry Cross, who is the founder and executive president of the Perry-Cross Spinal Research Foundation. Jenny Kroll-Rosen, who is the co-founder and director of Making Strides, our rehab partner. Dr. Andrew Rayfield, who's the research fellow and research commercialisation manager at the Clem Jones Centre for Neurobiology and Stem Cell Research. And we also have Fran Oini, who is the research fellow and social media manager at the Clem Jones Centre for Neurobiology and Stem Cell Research. So that's your panel. And I'd now like to ask Professor James St. John to present to all of us.
Thanks, Jen, and good afternoon, everyone. And we're very excited to have you all joining us online for this information session. As Jen said, I'll be doing a short presentation which will address the critical aspects of the trial, and then we welcome your questions. I'm just going to share my screen and see what I can get going here. All right, is that working, Jen?
Yes.
All right. Okay, we'll start off with an acknowledgement of country. Griffith University acknowledges the people who are the traditional custodians of the land. We pay respect to the elders past, present, and extend that respect to all Aboriginal and Torres Strait Islander peoples. So we are at Griffith University. The Clem Jones Centre for Neurobiology and Stem Cell Research is based on the Gold Coast and also in Brisbane. And we're a team of over 40 people who've been working towards getting this therapy into clinical trial. In addition to our team, we also have a growing number, almost 200 people, clinicians and allied health specialists who are working towards getting this trial underway. So I'm sure you've seen the media announcements. We're getting lots of attention about the launch of our clinical trial, and this is what we're here to talk about today. So to get to this clinical trial, it's been a major effort, and we've got lots of partners, and we have to understand that it's a cross-community collaboration, and we're very thankful to everyone who's been supporting this work and getting into clinical trials. It certainly is a great partnership for everyone. I'm sure all be very proud of having achieved this major step of getting this trial underway. The major funders of the preclinical research, the Motor Accident Insurance Commission of Queensland, Perry Cross Spinal Research Foundation, and the Clem Jones Foundation. For the clinical trial, we have funding from the Queensland Government and the Medical Research Future Fund. We've also got incredible support from the community, donors, mums and dads, brothers and sisters, plus also some very big philanthropic donors. And so we're very, very grateful to everyone who's contributed to getting this trial underway. We've also spent a lot of time communicating, engaging with the community, the spinal injury community, to see what people want. And we particularly highlight the Spinal Injury Project Consumer Panel. This consists of 7 people who live with spinal cord injury from around Australia. And they've helped us design the trial and plan what the patient journey will be through the trial. So they've been critical supporters and co-investigators on this for the trial. So this is the design of the trial for the cell transplantation group, the people who will be receiving the cell transplantation. So each person will be on the trial for 1 year. In the first 3 months, they'll do priming rehab or prehab. This is to help get their bodies ready for surgery. Plus, also, if you haven't done much rehab previously, you might be able to detect some improvements in function that would have been missed because you haven't done rehab. During that period, there'll be a nasal biopsy. So we take a small biopsy from inside your nose. From that, we purify the cells, freeze them down when we have sufficient numbers of them. And then just before the surgeries, we can thaw those cells, revive them, and make them into a cellular nerve bridge, which is then transplanted into your own spinal cord injury site. So you're using your own cells to treat your injury. Then after a period of recovery, you then undergo an intensive long-term rehab for another 8 months. And during this period, there'll be many tests. We need to be looking for lots of different aspects. As we know, spinal cord injury affects so many parts of the body, so we need to be testing in different ways. And so there's quite an extensive testing regime. But that's to help us understand from a safety point of view if everything's going okay, plus also we're looking for functional outcomes. We also have to have a control group. And the reason we have to have a control group is because while rehab is available in Australia, people don't do intensive rehab routinely. Some people might do intensive rehab for a short period, but typically not for a whole year. So there's no data from which we can compare intensive rehab in Australia to for our trial. So the control rehab group will do exactly the same program of rehab. They just won't do the cell transplantation group, the cell transplantation in that middle bit, but all the rest will be the same for those people. And because it's this is an animation of what it might look like. We do a nasal biopsy. That process can take about 15 minutes. For some people, you might have general anesthesia, but typically it's local. The cells are then purified from that biopsy, and we make them into a nerve bridge. In our trial, we'll use open surgery to transplant the nerve bridges into the spinal cord. But in the future, like in this animation, we're hoping to make it minimally invasive through an injection method. But there will be open surgery for this trial. This is an animation that sort of shows what the cells do. Once their nerve bridges are transplanted into the spinal cord, they're secured in place using surgical glue. This is just already routinely used in humans. The surgical glue is that is. And the cells then migrate out from those nerve bridges, integrate with the spinal cord. And when they're inside the spinal cord, they do their magic, which is they can clean up the dead cells that might be there, and make a clean environment to encourage regeneration of your nerve cells. They secrete growth factors that also promote regeneration. And then they do their main job, which is to ensheathe and wrap up the nerve cells. So the nerve cells are finding their way to their targets, but they need to be protected and guided to their targets. And that's what these cells will be doing. So for the trial, the number one thing we're looking for is safety. because this nerve bridge transplantation has not been done before. The safety of transplanting of factor and sheathing cells has been tested before, and that was done here in Australia in 2002 in a trial led by Professor Alan Mackay-Sim. But that's where they injected cells, and other trials have injected cells. The use of the nerve bridge is new, so we need to show safety, number one. The injury level for this trial, we'll be looking at injuries from C5 or below. Unfortunately, we can't use C1 to C4 at this point, but I'll explain that in a few moments. We'll be starting with AIS A and B injuries, so complete injuries. But then as we see safety, we'll be moving towards AIS C injuries, so partial injuries, although they will be the more severe partial injuries, but will be certainly partial injuries. And again, as we see safety, we'll be starting at least 12 months after injury in the first part of the trial, but then we'll be progressing earlier, sooner after injury. So towards the end of the trial, we might be recruiting patients as early as 4 months after injury. We're also very keen on examining the differences between males and females. And so we particularly encourage females to apply. We need lots of women on the trial so that we can see whether this treatment is working in them. The whole purpose of this trial is to find out what types of injuries respond to the treatment. And that way we can, target those particular injuries or make the therapy better so that we can therefore target a broader range of injuries. So for these reasons, we're keeping it very broad. We don't know what type of injury will respond. So we want as many types of injuries in our trial. And I should say here, we are looking for acquired spinal cord injury. So that means if you weren't born with it, but you had it through some sort of accident or injury or disease later on, then that would be acquired spinal cord injury. So we encourage you to apply. We're going to have a staggered enrollment. That's because we need to go through safety. We're going to start with AIS A and B injuries, thoracic and greater than 12 months. But then we'll move up to the cervical injuries. And then as we see safety, we will move to the AIS C injuries, 12 months after injury. But then we might go earlier again, as I said, even as soon as 4 months after injury. So we'll be recruiting one person for the cell transplantation, one person every 6 to 8 weeks. That means, this might go for 8 years, 3 years. But we might be able to speed things up as we progress. But once we see safety, we can revise that sort of timeline. So what's the process? We're not ready yet for opening up for expressions of interest. We're getting close. We've just got some final administrative things to go through with the hospital. But once we have the expression of interest open up, there'll then be shortlisting, and the clinicians will be looking for injury types that they think are suitable and no comorbidities, for example, and maybe an injury that's more likely they think would be suitable for implantation. Then there'll be a period of pre-screening by the independent assessors who will be looking at the applicants. And then if they're then selected, they'll be randomized. People will be randomized into either the cell transplantation group or the control rehab only group. And I remind you that there's 20 people for the cell transplantation and 10 people for the control group. So you've got 2 to 1 chance that you'll be in the cell transplantation group. And then after that, the people will be enrolled. And we'll be, as I said, enrolling 1 or 2 people every 2 months. So what is the commitment? The commitment is 1 year. We really want people to stick to this. We don't know when responses to the treatment or functional improvements will happen. So it's a long journey. And for that, you're going to need support psychologically, socially, work-wise, because we're asking people to do 3 hours a day of rehab, 5 days a week for up to a year. We do understand that people need holidays. We allow people to take the holidays at different times, and after in the post-surgery rehabilitation, the first 3 months will be intensive. After that, people can reduce their intensity if they prefer, although we would encourage them to keep on doing rehab. The more you do, the more chance of success. So the questions are, when will connections be made? We don't know. But maybe if you, it might be 6 months, it might be 7 months, it might be longer than that. But if you stop at 5 months, then gosh, if only you had 1 more month, you might have seen some improvements. So that's why we really need people to stick to the program as long as possible. The function, there's a difference between, we might see electrophysiological connections, or imaging might indicate that there's improvements, but when do you feel an improvement, that might be different again. So, hopefully we can, assess things and encourage you to continue on the journey. As I said, the intensive rehab can be reduced over time. And if you need a break, you can certainly have holidays. To encourage people just to continue and to compensate you for your time, you will be paid $23 an hour. This is the base government rate. For every hour you're on the trial, you'll be paid. So you're getting paid to do rehab. So that's a pretty good outcome too, I think. And hopefully that will encourage people to continue to do the rehab. Okay, where are we recruiting from, and where is this involving? So the nasal biopsy, to taking the biopsy to get your cells, will be done on the Gold Coast, and then the cell transplantation will be on the Gold Coast as well. The rehab will be done either on the Gold Coast at Making Strides, Sydney, or Melbourne. In Sydney, it's going to be with Royal Rehab, and Melbourne, the next step. We will be recruiting from northern New South Wales, Southeast Queensland to start with, just because it's easier in terms of logistics, but then we'll be opening up to Sydney and Melbourne. And for those of you in the rest of Australia saying, what about us? Well, we're already planning the next trial after this one. That's Andrew Rayfield's job. While we're already so busy trying to get this trial underway, we are thinking about the next trial. So we very, very much encourage you to contact us and let us know if you'd be interested in, if you know the clinicians, rehab specialists, let us know, because we are starting the planning for the next trial. So we haven't forgotten about the rest of Australia, but there's only a limit to what we can do at each time. But we're certainly planning for the rest of Australia. And beyond that, the world as well. Okay, because I know I've got questions coming through about the high-level injuries, why not C1 to C4? We very much recognise the urgent need to repair high-level injuries. Unfortunately, the clinical team says that the risk of complications outweighs that, and so we need to see safety first. Because it can complicate respiratory function, we don't want to make someone's injury worse. But we are certainly thinking about that one. So again, if you have a C1 or C4 injury, please contact us. Let us know that you are keen to be involved, because part of our planning for the next trials is to know the demand for this treatment. So the more people who tell us that they want it, then we can have those conversations with the funding agencies, the investors, and the clinicians that, there's demand for treatment that's suitable for C1 and to C4. So what are the next steps? The next steps are that we are trying to get the final approvals to get this trial underway. We're opening up the expression of interest, when we can shortlist the applicants, and then after that, we can enroll the first person and get the trial underway. Safety is important, so once the clinicians are convinced of the safety, at least the interim safety outcomes, then we can really move this forward. So we're pretty excited to get this going. It's a lot of work. And we've got incredible support from the clinical teams, and they're all very keen to get this going too. For more information, please email us. That's SCI trial at Griffith, or you can scan the QR code there, and that gives you the links to our social media and websites as well. So that's it for me now, and then we can open it up for questions, and I'll stop sharing.
Thank you so much, James. That was great. Really interesting. Thank you. We've got a bunch of questions rolling in. One that I'll start with that was sent to us earlier from Joanna. When choosing participants, does it matter if their spine has been fused with a titanium plate and the spinal cord is not cut?
So Because one of the primary measures we're going to be doing is looking at medical imaging, such as MRI, for participants where metalwork might interfere with the imaging. We will be doing an operation to remove metalwork if that's considered to be clinically safe. This is a standard of care actually in New Zealand, where that metalwork is removed after 12 months for spinal injury patients. So it's not done in Australia, but it can be done. And so we'll be removing metalwork to make the imaging better, because we need to see that one. So having metalwork is not a problem. And as I said, it does depend on whether that metalwork is still required or not, but the clinical team will make those assessments.
Great, thank you. We've got a question here. If you live in WA, but you're willing to relocate to partake in the trial, is it possible to still apply for the first trial?
Yes, we don't encourage people to relocate. I mean, we good and bad. We expect a lot of people to be applying for this one, so we can't guarantee enrollments. Gold Coast is a wonderful place to live. In any case, you're welcome to come over. But yeah, some people have moved to the Gold Coast, but there's no guarantees. The recruitment and selection of people is independent of our research team.
Thanks, James. William has asked, is the treatment a one-time process?
It is for this trial. It's a single transplantation, but we already have plans for the future to have repeat top-up, and we're working on that. That's why I said with that, we have in the future working towards a minimally invasive procedure. So we envisage in the future there'll be a first operation to transplant the large nerve bridges, but then we can come in again later on with a CT guided deposition of smaller ones, maybe every 6 months or so, but that's in the future.
Great, thank you. We've got another one here around risk. Even though it's hard to gauge, how risky is the surgery considered in terms of somebody possibly losing the small feeling or movement they currently have?
Yeah, that's exactly the most important thing. We've got to make sure this is safe. We don't want to make someone's injury worse. The surgery itself is straightforward. The neurosurgery team are highly skilled. They're very experienced at cutting tumors out of people's brains. So this surgery here, where it's just exposing the spinal cord and implanting the nerve bridges, it's quite minimally invasive in that sense. So we don't expect complications from the surgery. Complications may arise from the cells. We haven't seen any complications in our animals. It doesn't mean that there won't be complications in humans. Sort of complications that we can perhaps think about. There could be inappropriate cell growth that could block, say, for example, the cerebral spinal fluid flow. That could happen. There could be increase because of increased connectivity, but that might not make sense to the body. There could be increased pain. So these are things that we don't know will happen. But as I said, we haven't seen those in our animal models. We have high quality cells in a good format we think is going to be pretty good, but we don't know until we try.
Okay. Jenny, a question for you. How often should you be exercising to prepare for such a surgery? Just get you to unmute.
There's not a specific number as far as exactly how many days or what your frequency or duration should be. But if we look at what the trial entails, it's 5 days a week for 2-hour sessions plus the additional FES. So I'd say if you can get to exercising most days of the week, which is just the ESSA standard for somebody with a spinal cord injury, then that would be recommended.
Thank you. That's great. Another question. If you are selected for the control group, could you later be selected for the transplantation?
I can answer that one. Yes, we've thought very carefully about that. We are planning the next trial, and so people who are in the control group will be looked upon favorably for the next trial. That's all we can say. And we are working on future versions that may be better than the first version. So Yeah, we certainly are thinking around those aspects of it. But at this point, no, we won't be doing the cell transplantation on the control group. But in future, they might be, as I said, looked upon favourably.
Okay, a question from Linda. Will participants have to live where you are for the whole 12 months, or can they rehab in their home state or area?
Yeah, so we will be recruiting people from, if you come from Southeast Queensland, you need to be able to get to the rehab centre. So Southeast Queensland, Northern New South Wales to Royal Rehab, which is on the Gold Coast. If you live in Sydney, you need to be able to get to Royal Rehab each day. And same in Melbourne, you need to be able to get to the next step. So if you are within an hour's travel of those places or an hour and a half, then you can do that. We will be paying for your transport each day as well. So it's just your time is required in that sense.
Just around there's a few questions here relating to the control group. Is that something you can opt to be in? What if you want to be in the control group but not in the transplantation group? Can you still apply and express an interest in being in the control group only?
Yeah, unfortunately, yeah, we've thought about this very carefully, and we know some people are keen to have, be in a control group because, okay, you get a free year of rehab, which is a pretty good outcome. And some people don't really want the cell transplantation at this point. But unfortunately, because this is a clinical trial that requires randomization, then we cannot do that. It will be a randomization. People will be selected into either the control group or the treatment group. This is just the way these clinical trials are done, and we're running this to their highest levels of international practice so that we can get approvals to go to the next trials and ultimately get this commercially available. So this is just the way that is, unfortunately.
Okay. A question from Tony. Once recruitment is open, how long would it be before a participant who meets all of the inclusion criteria would know if they are selected or not? Not necessarily knowing when they would start the trial, but at least knowing that they have been selected for the trial.
Yeah, we don't have a definite answer on that one yet. And we're working towards that. We'll let you know that sort of timeline in the future.
Okay. Just looking through a couple of questions here. I think you covered this off in your presentation, but perhaps you can answer in some more detail. Julie's asked, is the trial only for traumatic SCI, or is it also for people who've acquired their SCI through infection, cancer, or bleed, for example?
Yeah. So yes, originally we had said traumatic, but we've changed that because it can be confusing. It's now acquired. So as I said, if you weren't born with spinal cord injury and you've acquired it through some sort of injury or incident, then that is within our range of injuries that we're interested in. Again, it comes down to the clinical assessment of what they might think is likely to respond. So yes, but we ask people to apply.
Okay. A couple of questions just around relocating for the transplantation. So Jolly's asked, will you be staying at the hospital, for example, for a period of time, and then you'll relocate to do your rehab? What happens with prehab? So are they done locally and only the hospital stay is up here on the Gold Coast?
Yeah, so I can answer part of that one, then I might hand over to Andrew. But yeah, for people, say, for example, from Sydney or Melbourne, we'll fly you up. We will pay for that to fly you up to have the nasal biopsy and do the assessments. Then you fly you back down to Melbourne or Sydney. And then again, we'll fly you back up for the surgery. And then you'll stay in the hospital. Then we'll put you up in accommodation while you recover from that surgery because you probably can't fly back. And we need you close to the hospital in case there's post-surgery complications. And then, again, we'll fly you back up for the major sort of assessments such as the MRI scanning. Andrew, have I missed anything there? Is that all right?
No, that's essentially it. James, thanks.
Yeah. So yeah, it's a bit of effort for the Sydney people, but you come up to the Gold Coast every now and then. That's pretty nice, particularly in winter.
An interesting question from Max. if we are selected for the first treatment group and then years later down the track, once the treatment is perfected, will you top up the first treatment?
Yeah, well, that's what we hope to do. So, we are working towards a top-up treatment regime that we can introduce into future clinical trials.
Great. There's a couple of questions around timing. Everybody keen to see this becoming a treatment globally. So Sarah's asked, assuming safety and efficacy, do you have an estimation for commercialization when this will become translated for people?
Yeah, it's a great question. There's a great push around the world to fast track clinical trials and to get therapies out there for people with urgent unmet medical needs, such as spinal cord injury. So this first trial is going to be a bit slow because we really need to get through the safety. Once we show safety, then we can then fast track it. As I showed in my presentation, we'll be looking for multi-sites in the next trial. That means we can do lots of surgeries at the same time in different places. That helps us speed up things. So that'll be the next trial. And then beyond that, there'll be an international trial, multiple countries involved in it. And again, if we do them all at the same time, we can speed things up. But each trial will still take about, a few years. So it's going to be a while before it becomes commercially available. But there is certainly a push to speed things up. And that's why we're now planning the next trial, even though we haven't officially started the recruitment for this one here.
Great. This one, Andrew, you might be able to talk to this a little bit. Haley's asked, when is the intended date to get underway? Perhaps you can talk a bit about the process.
Very good question. We are, as James said before, very busy finalising contracts and protocols and all the paperwork with the hospital. It takes a lot of different people to make this work, and getting a lot of people to respond in time and get everything written takes time. We're hoping early next year to really get things rolling, being in mind that Christmas period is fast approaching, and there are only sometimes certain dates that committees will sit for or be able to look at new pieces of information that we give to them. So yeah, there's lots of little tiny hurdles that we've got to go through, but we're slowly making our way there.
Great. Thank you. Susan and a few others have asked around the timing of your injury. So how long post-injury are you still eligible for the trial? For example, if you were injured 40 years ago, is that an issue?
Yeah. When I first started working in neuroscience in the mid-1990s, it was impossible to repair the spinal cord, and people thought it would never be possible. We now know it can be repaired in some circumstances. We're taking the attitude that we don't know how long is too long. So anyone with an injury greater than 12 months to start with, and 4 months later on, can apply. We have no upper limit. So it can be a long after injury as you want.
Great. Okay. Just scrolling through. What about additional issues you might have? For example, rheumatoid arthritis. Perhaps you might be on immunosuppressants. Would something like that make you ineligible, or other medications or conditions make you ineligible?
Yeah, there are comorbidities and other conditions that clinicians will be looking at. It's a case-by-case basis. And so the clinical team will be working with the participants or applicants to see what's appropriate or not appropriate.
Okay. With the randomized control group, would there be an option for those participants at the end of the 1 year to potentially be offered the treatment if they are?
I think
So we've done that.
But I think that's
sorry,
okay.
doing a few things at once.
Yeah.
Okay. Thank you to Fran and Jenny, who are also typing various answers as we go.
And I am too. If I look a bit not connected.
Thank you. That's helpful. There's a lot of questions here. Does anybody want to raise their hand, use the button at the bottom of the screen and ask a question live to the panel, or are you happy for us to continue scrolling? That's also an option if you'd like to speak.
Yeah, we'd love to hear your voices.
We feel a bit lonely. We know there's over 100 people here with us. We've got here, if you have tendon or nerve transfers, would that be a problem?
Again, it's just on case-by-case basis. Clinical team will look at those ones.
Okay. I wonder, James, if you can talk a little bit about the great work you've been doing. I know you've seen results, but someone asked here, Nikki has asked, do you have any research that suggests this might help repair bowel and bladder issues? We know that's been something the consumer group and others are very interested in. I wonder if you can talk to that.
Yeah. So yeah, a bowel and bladder is the number one function people want to have restored. We'll be looking at that very carefully. And certainly in our animals, we get restoration of bowel and bladder function. So we'll be hopeful that this works in humans as well. So yes, this is again, when I talk to the media, it's not about getting people to walk again. This is about getting motor, sensory, and autonomic function restored. And we'll take anything that we can get. So we're looking at all of those. Jen, Fran says some people do have their hands raised.
Oh, sorry. I'll ask another question before I go to hands here. That'll cover off a few that are in here. Do you need to be an Australian citizen?
You have to be resident in Australia. Yeah.
A resident in Australia.
Resident.
Okay.
Yeah. So, for example, you can't be on a tourist visa coming here, but you can be if you're living in Australia. It's okay.
Okay, for some reason I can't see the hands. I'm trying to find, oh, here we go. Maybe if I go to participants, I can see there's some hands. Let me see.
The participants and then attendees. Yeah.
I'm in attendees. Sorry,
and then go to the names and there's a little hand next to each person's name. Do you see that? Yellow hand.
Oh, yes, got it. All right, Bob. Bob, we're coming to you. I'm going to allow you to speak. And then, Bob, if you can just take yourself off mute, you are welcome to ask your question.
Okay, I don't know whether I'd be, thanks for the chance of having a bit of input here this afternoon, guys. I underwent surgery, keyhole surgery for a spinal fusion in 2017. I jokingly said to the anaesthetist as they were putting me under, if you stuff it up, don't wake me up. Lo and behold, I came conscious in ICU. And I said, what happened? The good doctor at the time said, we lost the nerve response in your legs. So we shut up shop halfway through the operation, which erred on the side of caution, and I'll finish the job when I come back off holidays. I said, when's that? And he said, 6 weeks' time. And I won't tell you what my response to that was, but he said to me, well, you can't begrudge me going on holidays over Christmas with my kids once a year. I said, well, mate, you've got some sort of responsibility called to your patient. And anyhow, he came back in February and finished the job. I got out of Budrum Private Hospital in July that year. The nerve damage to my legs and the ongoing pain and everything else, to the extent I went to instigate legal action, and Shine Lawyers, what's known, APRA, had a look at it very conveniently, to my summation, kept the investigation going for over 3 years. When they handed down their decision against the doctor, am I allowed to name him?
No.
Yeah.
APRA very kindly kept the investigation going for just over 3 years. They handed down apparently 26 different findings against him, of which I know 7 of them were mine. What went on then, I went to instigate legal action against him, and the likes of Maurice Blackburn and Shine Lawyers said, sorry, but there's a 3-year moratorium on when you can instigate legal action. So consequently, 7 years or 6 years and a bit down the track, I'm still getting around on 2 walking sticks, and there's not a day goes past that I fondly remember this doctor in a different sort of a way. So yes, I'm very interested in this this study that you're carrying out, whether or not it would be of any interest to me. Yeah.
Yeah, well, certainly. Yeah, certainly. It just depends on the injury. If you've got partial function, then that would be AISC injuries. And so that would be later in the trial. So we certainly encourage you to apply, and the clinical team can assess your situation. Hopefully, as I said, hopefully we can offer a whole range of different types of injuries, a treatment. So that's what we're after.
Yeah.
Thanks for that, Bob. Really appreciate the question.
Okay, thank you.
Thank you, Bob. We've had a great question. What does it mean to be proven safe?
Yeah. Yeah. So if I said that before, we haven't seen any so proven safe in terms of the Alan Mackay-Sims trial. Yes, so in Alan Mackay-Sims trial, which is 2002, and for those of you who don't know who Alan Mackay-Sim, he was the 2017 Australian of the Year, and he was awarded that prize for having run the trial back in 2002. So in that trial, it showed that transplanting the cells into the spinal cord had no adverse outcomes. In fact, there were some small improvements in the people who were treated with the cells. So that was very encouraging. And because of that work, the Polish team continued to work with those cells and showed that there was functional improvement in that their trial back in 2013. If you look up olfactory and shielding cell trials, there are some trials that haven't had good outcomes. But when you look at what they transplanted, it was they didn't transplant high quality cells. In fact, they transplanted what I would consider, rubbish. You put rubbish in, you're going to get rubbish out. So our work has focused on getting a high quality cell preparation where we have very high purity of cells produced in the right way. Those early trials where they put whole pieces of factory mucosa in wouldn't be acceptable by any measure these days. Certainly not in Australia. So it's a bit different. But yeah, certainly the technique of injecting cells using olfactory and shielding cells into the spinal cord has been shown by several different trials around the world to be safe.
Andrew, a question for you. Do you have to be fully vaccinated against COVID to participate in the trial?
No, there's been a few questions about this. No, what is online at the anzctr.org.au, which is where the trial is registered, we're updating that. We've talked to the clinicians, and it's not necessary to have COVID vaccinations. It was left over from a previous feasibility trial, which happened during COVID. So yes, it's not a requirement, and I literally just removed it from the inclusion-exclusion criteria today, and that will be submitted again so shortly.
Great, thank you. I'll now go to Julian. Julian, if you'd like to unmute and ask your question.
Yeah, it's very simple. Is there an age limit for the trial?
Hi, Julian. No, there's no age limit. Oh, well, the minimum is 18. You have to be 18 years or older. We certainly recognise that, well, we know that one of the used to be young men or young people were the most prevalent group, young men driving too fast or playing sport too hard or whatever. But now almost equally, it's middle-aged men such as myself who fall off ladders at home. And we have a long life ahead of us thanks to great healthcare. Someone like me will still might have another 30 years. And so we are keen on, as I said, looking at a whole range of injuries. We want this therapy to be as widely suitable as possible. So we encourage people who are older to apply. Yeah.
Thank you.
Thank you, Julian. Let's go to Gus and Kim. If you can unmute, please go ahead and ask your question. Still on mute. Gus and Kim, if you'd like to ask your question. Okay, we might move to Bruce instead.
Yeah, hello.
Oh, sorry, Bruce. I cut you off. Hang on a minute. There we go, Bruce. You should be back now if you just unmute.
Okay, can you hear me now?
Yes, we got you. Sorry about that.
Yeah. I just wanted to know that I'm an incomplete quad. I got diagnosed C4, C5, but since my injury, I've got a lot of return back above C5, like biceps working, shoulders shrugging. I'm more C5 than C4. I probably must be a tiny bit C4 still, but mainly C5. And I've also got ankylosing spondylitis, so the two different questions, but I'm very incomplete quadriplegic and I exercise 4 to 5 hours a day, which I've been doing for the last 14 years. And I stand up on a machine and do all my own exercise and keep myself moving everything I can since that whole time. And so would I get another ASIA test or to see if I'm more C5, or would I qualify being a touch C4? Just inquiring about that.
That's a great question, Bruce. And so certainly we encourage people to not take your initial diagnosis and assessment to be what you are now. We know injuries change over time. So people might have been an AIS A and now they're a B, or they're a B now they're a C. Plus also injuries, we know they can progress upwards or resolve in some ways. So a reassessment, and we can assist with that too. If you haven't had an ASIA test, we can arrange for one as well, to make sure that you are in the category that you think you are. So if you please apply, and we'll help assess whether you're suitable or not.
And the ankylosing spondylitis.
Again, that one there, the clinical team will look at it. I'm not a clinician. I'm not going to answer that one. I was going to say, I know that's a condition. I understand what that is. But I don't see why that may have effect, but I'm not a clinician. So the clinical team will assess those complications, but please apply and then go from there.
Materials before and all that sort of stuff. So I was hoping it wouldn't. Okay.
We're dealing with people, and we have to make sure that our treatment is applied to people with all their complications. But some of those complications might just be clinically not suitable, but others don't matter in terms of this transplantation. So the clinical team will assess that.
All right, thank you very much.
Thank you, Bruce. I wondered, James, is it worth talking through there? You were talking about the clinicians and how those decisions were made. Perhaps it's important just to reiterate that it's independent of you. Mm-hmm. Did you want to talk that through?
That's a great point. So we have the pre-screening of when we get the expression of interest in, we have an independent team who will go through those ones and talk to participants, maybe ask more questions, find out which ones are in potentially, or ones which are definitely not. Then they'll be also considering other aspects such as where you live. Can you realistically get to the rehab centres? Do you have good social support? Because let's face it, doing rehab like this is going to be intense. Plus also having the cells is going to be intense. So there's a whole bunch of factors to see whether you're going to enjoy the journey and are you suitable. So we have this independent team. We as researchers won't be involved in that. And the clinical team will be then taking that shortlist and assessing which ones of those ones are clinically suitable as well. So we'll have a physiotherapist doing the first assessments, and the clinical team will find out whether you're clinically suitable, but it's all independent of the research team.
Okay, great. Jenny, a question around rehab. about the rehab program and process. So will this be activity-based therapy, or is it a more traditional type of rehab? Do you want to talk to the project and, the program and how it's tailored to each individual?
Yes, sorry. Hi, Elodie. I was actually just typing your answer, so this will be a lot easier. It is considered activity-based therapy, but you can say that it's a conjunction of using some traditional forms, because we will be doing some strength measures. In the feasibility study, we were doing 5RM testing, so we were looking to for it to be quite subjective. So we would look at everybody's strength maxes and then work from there, and that was part of the testing measures. But as far as the basic premise of neuroplasticity, which is largely what we're looking at with 5 days a week and layered exercise, it will be largely activity-based therapy. So some people may be crawling where somebody else might be working on gait training, and then will be everybody's program will have some form of load bearing, but it'll be very much tailored to you. I did see another question that came in, which was asking how to prepare. And again, there's not one typical type of preparation. It's not like all of us are going out to do a marathon, so we know the exact specific distance that we're going. What we know that we're doing is we're preparing for, in a marathon, in essence, that we're preparing for more of what we think of as an endurance event. So we want to make sure that our bodies are not only fit and healthy, but we're also looking at our lifestyle in the sense of what are the barriers to being able to come to the gym a couple hours a day. So that's as important as actually getting yourself ready. Also looking at, if you were able to layer exercise day in and day out, how are we going to rest in between? Because I think a lot of people get confused with the word intense, because the word intensity, what we're talking about is more just frequency. So what I would say is, what type of exercise can you do? You want to include some form of strength training and some kind of cardiovascular aerobic training. And feel free to email me if you want to go over specifics of what the nature of your injury is and what that could entail.
Great. I'll go to another live question. Perhaps I can ask Riley Green. Riley, would you like to? Oops. Sorry, guys. Let's go to Riley.
Hello,
Hopefully
I
it
think
works for you, Riley. If you unmute Riley, you should be
I think Jen,
able.
you got the other one, Maya.
My
yeah, I
apologies.
think you unmute me, Jen.
Oh,
I'm happy to
apologies.
wait for Riley to talk. You can unmute me later.
Okay. All right, Riley, you go ahead, and then Maya will come to you.
All right.
Okay. Thank you. I was just asking about the application process and what would be asked of us. For example, would we want an updated Asia test or any doctor's notes we need to have prepared?
Yeah, that will become clear through the EOI. So the EOI form's quite simple to start with. It's just general questions about your injury, time since injury, where you live, and then after that, then there'll be more questions. So there will be questions from your doctors, but the assessment team, independent assessment team, will contact people for those ones. So you don't need to prepare anything now, so the EOI, the expression of interest form, is quite straightforward. You should be able to answer all those questions without having to provide that supporting information.
And so with a traumatic spinal cord injury due to a ski accident about 4 years ago, I then had some stem cells through another trial, and I'm wondering if that would exclude me from this. I'm now classified as an Asia A, but I do have full, I'm a very unique case because it's only in the sacral sensation and calves that I have the issues. I'm still able to walk without supports.
Yeah, great. Well, that's one good thing. So we know that this therapy is targeted towards people with chronic spinal cord injury. I should say that we do think our therapy would be useful for acute spinal cord injuries, but because of safety, we don't want to try that one at this point. Because it is towards people with chronic spinal cord injury, we know that many people will have tried therapies. So we are not, having tried a therapy previously is not an exclusion factor. So we encourage people to apply.
Thank you.
Thank you, Riley. All right, Maya, would you like to go ahead?
Sure. First of all, I just want to say thank you again for an amazing job that you're doing all. My question is related to the number of people that you are recruiting, and how many people are you recruiting at the moment, and also how many applications do you have? Basically, my question is the chance of person who applied. So there's people live with hope. So just want to see how.
Yeah, so great question. So we're looking for 30 people for this trial. 20 people will have the cell transplantation and 10 will be in the control group. We know there's going to be a lot of people who want to put their hand up for the trial, and we're very thankful for everyone who wants to participate in this trial. We ask for as many people as possible to apply, and the reason is twofold. One, we want to be able to select the best candidates for the trial. This is a collaboration between the spinal injury community and the clinical team and the researchers. We all want this to be successful for everyone's benefit. So we want the best candidates to choose for the trial. Plus also, it helps us to determine demand for a treatment. If we can show there's demand, there's more people, then we can raise more funding. That helps us get the next trial underway sooner. So the more people who apply, the better. So I know what you mean. Yeah, you individually you might want to be selected, but as a community, we need to be getting behind this one and showing that, wow, this is what people want. So please apply. For those who don't get selected, we feel for you, but we're working very hard to make it expanded as soon as possible. But thanks for that
Thank you very
question.
much. Thank you very much.
Great. Let's go to Peter. Peter, would you like to ask your question? You just need to unmute. Have we got you there, Peter? Okay, we might move on then to Julian.
I'm so sorry.
Oh, there you are, Peter. Great.
I've got a chin operated thing and my monitor went off. So I
Apologies,
had to
no problem.
switch it on. Thank you so much for this seminar. It's great. Firstly, there's a lot of criteria I don't fit. I'm in Western Australia. My injury's too high at C2 incomplete. And the airlines won't fly me. However, all of that said, I want to talk about the risk factor. If I was somebody who chose to obviate the risk, sign whatever disclaimers were, because I'm now 75 years old, the end of this trial might be 2 or 3 years, 78. This is going to be my one and only shot. And there's a significant life improvement opportunity. And providing I've got all my affairs in order, if it goes down the other way, if I don't really care, where do we go then? I mean, I'm very keen to get going on something like this. I understand the risks. I'm a difficult subject, but I want to have a go.
Yeah. Yeah.
I'm sure
Yeah,
Perry
so-
Cross can agree with me there.
Yeah, definitely.
He's sitting in a wheelchair very much like mine.
Absolutely. And I know Perry's keen on getting treatment for the high levels. Look, yeah, we very much appreciate your situation and understand it. And thanks for sharing your story with us. We encourage people with the high level injuries to apply or contact us at least with the through the email. And you certainly put your expression of interest in as well. When we show demand and the clinical team sees that, they may reconsider. When we see safety coming through, the trial design can change. We can put variations in. So while it's now currently not for the high level injuries, it is possible that we could put a variation in to conclude them if the clinical team thinks it might be safe.
Yep. It was the risk. It was the risk factor I was more concerned about. If I negated any comeback on the surgeons, how would that? Damn the alarm! Hey Siri, turn off the alarm. Sorry.
Yeah, that's all right.
Everything's voice control for me.
Yeah.
No,
Maybe Perry wants to answer that one.
Yeah, Peter, thanks for your question. And James, I might just jump in and say, I'm keen to
enroll for the trial myself, even though I'm not eligible, I'm going to put my expression of interest in, because I think that information and that data is important to demonstrate to the decision makers that there is a serious interest from people with significant high-level injuries, and the sheer number of people with spinal cord injuries, whether you fit the criteria or not, we need to show demand. And I think it's important that everyone understands that what we're doing is generating a need for a treatment. It's obvious in our minds, people living with spinal cord injury need a treatment, but when you show demand and we come in numbers, then the decision makers get a different outlook, because sometimes they don't see what we see.
Thank you. Thank you all very much.
Yeah, can I also say what Perry said there is exactly right. We were successful with getting the Medical Research Future Fund to co-fund this trial with $6.8 million because we had huge community support for it. So the same applies when we want to put in a variation or modification to the trial or to design the future trials. If we show that there is strong demand for the high-level injuries, then the funding agencies will look favorably against to that sort of application. We know that people with the high-level injuries have much more to gain, and so we're desperately trying to get this therapy underway. So please apply.
Will do. Thank you.
Thank you.
Thank you, Peter. I'm going to go to Michelle. Michelle, if you can unmute, go for it.
Hi, I'm in Tassie and I had a car accident back in 2011. I'm incomplete and I do basically rehab daily, and now to the stage of gait training. I can't feel below my knees, all different things. I know that I'm not going to be right for this one, but I noticed the dot that you put there for Tassie and that you're looking at 2026. Are you interested in also, do I put in an expression of interest now for that, or do I wait until later? And secondly, are you interested in, say, physios and physiologists and things like that? Like I've been working with people for 13 years now. Are you interested in them putting themselves forward because they've dealt with spinal injury, or?
James, you're on mute.
Thanks, Jen. Yes, that's exactly right. Please contact us. Let us know you're interested. If the physios, EPs are keen, get them to contact us. We want to build this network. We are going off to the conference in Perth, which is the Australian New Zealand Society of Spinal Cord Injury. We'll be presenting there. We want to build the networks and see who's interested in having that next trial. So please just contact us and let us know.
Awesome. Thank you.
Michelle, we'll circulate the email that you can use to make that contact after today.
Okay, thank you.
Thank you. Just a question here around, a couple of questions around whether there'll be regular updates to the community, the broader community, as the trial progresses, and then also how will the results be published? So how will people in the community hear about how well the trial's gone?
Yeah, so we'll be when it's appropriate, we can give interim updates. There's the official properly analysed results that will take some time to come through at the end of the trial, but there will be interim updates about safety or progressions, and so we'll be using social media. We'll be communicating through the Pericross Spinal Research Foundation and other organisations such as Spinal Life Australia, and through other networks. So we very much recognise that a lot of our research has been kept under wraps for different reasons up until now, but we're at the point of the trial, we'll be increasing our social media communications.
Just further to that, Sarah's asked, has any of the preclinical data been published? How can they read that?
So no, a lot of we are focused on getting this therapy out into the community as soon as possible. For that to happen, it's quite an expensive journey. The previous trials, such as Alan Mackay's Sims trial back in 2002, didn't progress because the work was published. Unfortunately, for better or worse, the reality of the world is that science is a business. Every drug you buy from a pharmacy by script that's gone through clinical trials have cost $1 to $2 billion. A trial for spinal cord injury will cost at least that much money. And the only way you're going to get funding for such a massive international trial is through big multinational investors. And they will only invest if you have a intellectual property portfolio that protects the product. So because we're working towards patent applications, our work has not been published yet. We've published some papers around the biology of the cells, but not the critical data on the preclinical animal research or the in vitro research. That will be coming in due course, but we want to make sure that this is successfully translated through what they call the valley of death. Too many therapies fail because they publish their results and investors don't want to come in. So we have a very strong commercialization plan, and we are following that to the frustration of our research team who do want to publish. But we are focused on the big goal of having a therapy out there for everyone. So
James, can I add to that as well? For people that are concerned, we have to let the hospital ethics committee that approves our research, we have to do what's called an investigator's brochure, and that includes the information from our preclinical studies. So it has been checked and looked at by the ethics review board. So and that ethics has been approved. So just on top of what James said.
Great, thank you. I'll encourage everyone to continue with their questions. Thank you to the panelists who've been answering them madly in the background. We're actually getting through a volume of questions here, so thank you. I'm going to go to Ken in a moment, but if you have a question you'd like to ask, please use the Q&A function, or you can lower your hand and I'll come to you to ask the question live. Ken, I'm going to go to you now. If you can unmute and ask your question.
Yeah, good afternoon. Look, my problems began in 2018. I had an operation on my lower spine. I don't know the number of it. All my nerve endings were getting crushed. I got a staph infection whilst I was in hospital. 17 weeks to get rid of that. And so I lost all my muscle tone in my back, and I was bent over at 30 degrees and going even further. So we got hold of my surgeon again, and he put in some rods from T4 to T10 to straighten me up, which I think it did a little anyway. But then I was home only a short time, month maybe. My wife said, stand up straight. And I said, I am, but it hurts. So she said, go back to the surgeon, and he did a scan before I got to him, and he said, I can't see anything. And from what I believe, he only did a scan from T4 to T10, where he operated. I was only home about another day or so, and I lost the use of my left leg. And then I went to bed and went to get out, and I slipped out of the bed, and I realised I lost the use of my right leg as well. So to Gold Coast Private Hospital, which are very good, and emergency, and the emergency doctor says, he couldn't see anything at first glance. He said, we'll do an MRI. But in between, because the MRIs take a while because I have a pacemaker. And so he did another scan, and he said, look at this. And it was T2 and T3 were cracked, pressing on my spinal cord and cutting it partially. And so I had to have an operation within 2 days, otherwise I would lose the use of my arms as well. We had that, and I had no feeling from my chest to the bottom of my feet. I kept exercising and physio to the point that I excuse me. I was told I would never walk again. So I kept exercising, and with my physio here where I am now, I'm in New South Wales on the Gold Coast. I can walk with one of those four-arm walkers. Not very fancy, but I am a bit pleased with myself being able to get this far. So I'm just hoping that, because like I heard you mention before, between T2 and T3, I'm not in the program. Would that be correct? Oops.
No, Ken, so we take anyone with thoracic, so T1, T2
Yeah.
will be included. Yeah, that's absolutely right. We just won't be not lumbar injuries.
Yeah, I'm joined up to T2, T3 onto
Yeah.
T4 now.
Yeah.
And that's why I have that movement without cutting the rest of my spinal cord.
Yeah. Well, thanks for sharing your story. It's it's dramatic, and we wish you the best. But yeah, certainly, as I said, we're looking for different types of injuries, so we encourage you to apply. And you're certainly in the right level of injury, so that's fine from our point of view. Yeah. All right. Thanks so much, Ken.
All right. Thank you.
Thanks.
Let's go to Mayada. Sorry if I got that wrong. If you want to just unmute.
Hello.
Go for it.
Hi, yes, so I just wanted to ask, if someone gets selected as a participant in the control group, do they also get a chance next time or during the same trial to be a part of the clinical trial? So the other 20?
Yeah. Unfortunately for this one, no. The reason is actually the cell transplantation is very expensive. Just for information, the cost of producing the cells and also the transplantation is probably around about $250,000, and we don't have the funding for that one. We were thinking about looking at funding for the control patients. It's beyond the scope at this point, but we are looking at whether in the next phase, next trial, those control patients would be a priority patient, and that's certainly a model that's been used by other trials around the world. So if you are in the control group, as I said before, we'll prioritize selection for perhaps a future one.
Okay, thank you. And can someone choose not to be a part of the control group?
The randomization, unfortunately, the randomization means you're assigned to the control group. Under clinical trial rules, people are free to withdraw at any time.
Oh, okay.
So, but again, think about what rehab, and I'm looking at Jenny here. If you're getting a year of free rehab and you're paid to do it, it's a pretty good deal, I reckon, if you're doing it.
I'm asking on behalf of my dad, and he just was once offered to be a part of a control group previously. So he's just now looking into, being under surgery for the clinical trial. But either way, I'm sure he'll be, grateful for being any part of in the clinical trial. Yeah. Thank you so much.
Yeah, we certainly appreciate that, people in the control group might be really keen on being in the cell transplantation group. We've struggled with this ourselves to think about how it can be done in other ways. Unfortunately, the regulators have said, no, it has to be randomized. We cannot sort of direct people into groups. And this is what we have to do. So, yeah, anyone who volunteers for the trial, this is a collaboration between us and the community. We're very thankful for people being on this trial in different ways.
Yeah, we like to think that those who end up in the control group, the positives are that is just piggybacking what James was saying, that you have a year of what we're going to say actually paid training, which you almost feel like a celebrity when you're getting paid to work out every single day and just become the fittest version of you. And then with that, we would hope that the results are as widespread as potentially similar to the other group. I mean, we want the cells to continue to obviously expand and grow, but we also think that a year of this type of training will reap some very large benefits as well.
And maybe can I add to that, James and Jenny, that we are keen to prove to the government and the decision makers that rehabilitation alone is beneficial for people. At the moment in Australia, when you're discharged from Australia post spinal cord injury, you're not encouraged to continue with rehabilitation. We want to disprove the fact that there's no benefit. So people being in rehabilitation alone is a critical, you know, what's the word? You know, I can't think of the word, but you know, it's important we have those people, you know, doing the work that keeps them fit and healthy for a long term, regardless of having the surgeries. So we want to see people, you know, exercising regularly, but we want people being discharged from hospitals with a rehab plan. We want that to be the protocol in the country, not, you know, not just for those who can afford it.
Yeah, based on the 2 feasibility studies that we've run at Making Strides, we were able to see that not only were people reporting as far as increases within their mood, so their DAS was changing, so just psychosocial changes, but we also from there saw that they were able to reduce, which are very scary secondary complications that unfortunately follow this injury. So we'd like to think that the cells and the rehab is what we like to think is the gold standard, but that either way, that you're also going to be in a better position than you're in right now.
Yep, thank you so much for sharing all the pros in that. I will definitely get that through with my dad, and thank you all for everything you've been doing and sharing with us.
Great, thank you so much. Justin, I will go to you now. Justin, if you want to unmute.
Yep,
Great.
all done. Hey guys, just want to say a massive thank you for all your hard work. I've just got a question regarding price point. So if approved, what would the cost of the surgery be and all other expenses look like for the public?
Yeah, that's on mute now. That's a great question. So we need this therapy to be accessible. Within Australia, there is a scheme that once the therapy is shown to be effective, that the government will bear the cost. As we know with cancer treatments, they are very expensive, hundreds of thousands of dollars of treatment, but the patient doesn't pay for it. So if we get this onto the Medicare system, hopefully the government will pay for it and it won't be a cost for the individual. But we've got to show efficacy first, and that means we have to have a trial, and that trial has to be run to the highest international standards, which is why we have to have the control groups and go through these processes of showing safety and then efficacy. These will be expensive, but at the same time, our team is working on reducing those costs. One way of reducing the cost is having that minimally invasive injection method, so therefore we can remove the surgery costs. We are also looking at ways of reducing the cell production costs. So we have an upper limit of the costs at the moment, but we are certainly working to bring those costs down, which will help the government make the decisions that they should fund it.
Excellent. Thank you so much.
Can I just add to that as well?
Yep.
As part of our team as well is exploring, and we're doing the work to look forward into the future beyond phase 2, beyond phase 3, after the therapy has been approved, all going well, what we need to do to make sure that that we have payers for this therapy. So we're looking at that now, and payers being, like as James said, the government, and how that's put onto different schemes. But we're actually doing that research now. It'll take a while, but we'll get there.
Okay, excellent. Thank you so much.
Right.
Justin. Let's go to Emma. Emma?
Hey guys, can you hear me?
Yes.
Oh, hi, I'm here with my husband, Rod. We're just dialing in from Sydney, along with everyone else, saying a huge thank you to all this incredible research that you're doing. We're so grateful. My husband, Rod, who's with me, acquired his injury almost 12 months ago. December will be 12 months. Motor vehicle accident, T5, Asia A. We're in Sydney. And Rod's question here with me, he was saying, if you do get into, into the trial, but you get selected to be in the control group, and we are from Sydney, do you still have to fly up to the Gold Coast for initial treatments and things, or do we just stay in Sydney and we start the process down here?
Yes, yeah, that's a great question. So we'll be doing the metal work removal if you have metal work.
Yes, he does.
Up here in the Gold Coast, and also it's the critical assessments such as the medical imaging, MRI imaging. While we know that Sydney has the capacity for that one, just for in terms of the analysis of the data, we want the people to be on the same sort of imaging suite. So we'll be flying people up from Sydney, but we'll be paying for flights and accommodation. So
well, I guess my other to that question, sorry to jump in, was of course, if they are in the control group, they still go through the same process as like you were saying, metal removal, even though you aren't having the cell.
Yeah, the metal removal is not for the surgery aspect, is so that we can image the spinal cord. So what we want to be doing is using, say, magnetic resonance imaging and other types of imaging to see the spinal cord structure and the pathways that might be there. And when we put the cells in, what we hope to see is that there's change over time. That tells us the cells are doing something. Maybe the person with a spinal cord injury can't feel things happening, but maybe if we see things happening, that can encourage the participants to keep going. It can also be evidence that we are heading in the right direction. So that's why we have to have that imaging at regular intervals.
And even if you aren't having the cell treatment, you're in the control group, you're still having the metal removed, but then going through with physiotherapy. There's no, I guess, like you were saying, in New Zealand, they take them out anyway. Really been talked about it here as to what happens next. So
So there's sorry.
Yeah.
I was just going to say there's no actual sham surgery, they call it. So you won't actually go through a surgery if you're a control group, only for the metal work, but not for the actual transplantation. You won't do some sort of like surgery where there's nothing put in. That's not happening. Just during that stage, you won't do any surgery. You'll just have a break.
Okay.
Yeah, actually, that's a great point. Thanks, Andrew. So for the control group, the people will obviously know they are in the control group. There will be no sham surgery. It's just the assessors of the people. They won't know. So we ask the people who are in either group not to tell the assessors, hey, I'm in the treatment group, or hey, I'm in the control group, to avoid doing that. So the assessors can independently, without bias, work out what changes might be occurring. So it's not that technical reasons, for those who understand. A double blind is when the participants don't know what treatment group they're in. But of course, in this one, sham surgeries are not ethical these days. So, people in the control group will know, obviously, they haven't had the surgery. Yeah. Okay, thanks for that one, Emma. That's great.
Thanks, Emma. All right, Matt, let's go to you.
Hi, can you guys hear me?
Yes, we got you.
Out of curiosity, are there any exclusions to the type of rehabilitation for those that are going through with the trial? I know, well, me personally, I'm attending Raw Rehab's LifeWorks, where they have all the different technologies there as well. Are there any exclusions?
No. We'll touch on that one too. So there's fantastic rehab around Australia. We're working with Making Strides here on the Gold Coast, and said Royal Rehab in Sydney, and the Next Step in Melbourne. And we know that there are other great rehab facilities providers as well, and everyone does things differently, which is great. We're not here to test what type of rehab works or doesn't work. We accept that we're not us researchers, we're neuroscientists, we're not so much rehab specialists. And we allow each rehab provider to use the type of rehab that they think is appropriate and suitable, and what facilities they have. So there's no exclusions. We welcome all types of rehab, and depending on what your provider is. And we know Royal Rehab's got some really high-end equipment, which is brilliant. And the Next Step does things differently as well. So it depends. It's very much personalized. Yeah, but no exclusion criteria from a rehab point of view.
Can I just add?
Thank you.
There are inclusion and exclusion criteria as part of that, and they can be found online. There is just maybe answering that question. There is exclusions around if you can't do functional electrical stimulation FES. So if you have a cardiac pacemaker, etc., you would be excluded. Yeah.
Okay, thank you. And also thank you also for the hope you guys are sharing. I think this is incredible.
Great, thank you.
Thank you so much, Matt. And I think that's a lovely way to close out the session, actually. I just want to thank all of our panelists for taking the time to be with us all today. Thank you to everybody who has attended. We're just so pleased to have such engagement and interest from the community. Thank you. We will be sending out an email which will have this recording, should you want to share it with your family. And in that email, we will also share the email address for you to ask any further questions to, and we would encourage you to do that. And now I will give the final word to Mr. Perry Cross.
Thanks, Jen. I just want to also say thank you so much to all the panelists today. It's been great to chat openly about what's happening. It's been a long time coming, but at the same time, we're just getting started. The exciting work is ahead of us now, and I would encourage everyone to, stay fit and healthy, stay well, stay interested in what's happening. Technology is going to evolve in the next few years, and this trial is going to evolve, and it can evolve quicker than we anticipate if we get good results. So I would encourage everyone to stay hopeful and optimistic about the work we're doing. So please, stay tuned to what we're doing. So but I just want to say thanks to the community. Over 130 odd attendees today. That's huge. 260 people registered. So the interest in this is massive, and we're very grateful for everyone's support to make this happen. It's only been possible to do this with the support of our community. So thank you.
Thank you, everybody. I'm going to end the session now. Thanks so much.
Thanks a lot.